A. Mason is a 9-year-old African-American male who was brought into the clinic by his parents with a chief complaint of nighttime bedwetting, which his mother stated started 3 years ago when the patient was 6-year-old. These episodes are steady and occur nightly, with no incontinent episodes during the day. The child states he is embarrassed by his bedwetting because he has a 3-year-old sister who doesn't wet her bed at all. According to the mom, the patient was treated for bladder spasms in 2015, but after 2 weeks of medication use, she discontinued the medication, stating that she felt it was ineffective. Since that time, the episodes have continued and progressively gotten worse. The child is not allowed any liquids after 6:30 p.m. There are no reported aggravating or relieving factors. The child is articulate and has many friends and excels at school. The patient has no history of eyes, ears, nose, throat issues, no noted drainage, redness, or swelling. His oral mucosa is pink and moist, and upon assessment, I noted wheezing, heard in bilateral lungs. He had no abdominal distension. Hypoactive bowel sounds were present in all 4 quadrants. No bruising noted in his upper or lower extremities, his trunk, inner thighs, back, genital area, or his buttocks. For his differential diagnosis, I started with 1, congenital abnormality, because it causes UTI, continuous incontinence, and dampness, and daytime voiding. I could rule this out because the child has no daytime voiding but does void continually throughout the night. My second diagnosis would be emotional disturbance. Depression and or defiant activity may be underlying features with urinary symptoms, and this may be ruled out by a clinical diagnosis from a behavior specialist, and also a urinary tract ultrasound. My third differential diagnosis would be UTI. It causes voiding dysfunction such as frequency, urgency, withholding maneuvers, and abnormalities in the bladder emptying. I completed a urinalysis, and the dipstick was negative for leukocytes, nitrates, and other bacteria. My fourth differential diagnosis will be nocturnal enuresis. It's the nighttime loss of bladder control that usually occurs in children around the age of 5, and this patient started at the age of 6. The plan would be I would obtain UA, possibly a urinary tract ultrasound, educate the parents and the child on keeping a voiding diary, and also ensure that the child limits his liquids 2 hours prior to bedtime. I also want to prescribe demopressin 0.2 milligrams PO to take 1 tablet 2 hours before bedtime, and I would like the patient to follow up in 2 weeks for UA results, medication effectiveness, and results of the urinary tract ultrasound. For my self-directed research, I would like to research detrusor areflexia. I'm not familiar with this term, which is urinary neurologic pathway innervating the bladder for damage. Do you have anything that I should?
So let's go back. What was your number 1
My
differential diagnosis?
My number 1 differential diagnosis was congenital abnormality.
Okay, so we're gonna look at doing a ultrasound.
Yes.
And if the ultrasound doesn't show us much, then what should you think about doing next when it comes to diagnostic?
Maybe an X-ray
or CT of the abdomen and pelvis, just to make sure that the structures are all all patent and working properly. Okay, then number 2, when you were examining the patient and asking the patient about did anybody ever touch him or anything like that, was the mom and dad present?
The mother was present.
Did the child look like it kept looking to mom like for answers or validation?
No, he actually answered the questions on his own.
Okay, so another thing I would say is sometimes kids are afraid to say things in front of mom and dad. I will ask, can you bring the last report card in? Or we can ask the teacher to write a note if they notice anything at school. Like, is there any problem? Does the patient have to use a lot at school? Do they notice? Has the child had any accidents at school? Just some things that the parents may not know, but the teacher notices. So we can have another person who's with that child for a long period of time. Then also, if there's any behavior issues, the teacher's gonna say, yes, this is what's been going on. The parents may not know or may not want to know.
Yes.
Mm-hmm.
Thank you.
You're welcome. Then your third one.
My third diagnosis would be urinary tract infection.
Okay, so you did a UA, you did a dipstick. We're going to send it out for UA, but we also want to do a CBC to look and make sure, does he have a history of having, like, is his white count right now elevated? And if so, is it the neutrophils, the eosinophils? What is it, the leukocytes? We need to see what's going on to make sure it's not an infection. Okay.
And my fourth one was the nocturnal uresis.
Enuresis. Okay. So it started at the age of
6.
Right. And so we know that most of the time they're diagnosed after the age of 5.
Yes.
And as long as everything else pans out to go in that direction, no congenital problems, no physical, mental, or any abuse, no problems at school, being bullied or anything like that, no signs and symptoms of infection, then I think that's the appropriate diagnosis. And then what we do is put him on that treatment. We wait about 2 weeks, see what mom says. If the incontinence episodes have slowed down. If not, well, maybe if they have, but we still need to slow him down more, then we can go up on his treatment until we get him to a happy medium where he's not having these episodes.
All right. Thank you.
You're welcome.
Okay.